So in this module, let's talk about the causes of postoperative fever and wound infection. All of these are very practical aspects which as interns or as postgraduates you face routinely in the surgical wards. Now, up till the previous module, what we've discussed is that the surgery of our patient is over and now the patient has been shifted to the ward and now our patient is running fever. So we need to analyze what are the causes of fever in this postoperative patient. So the causes of postoperative fever, POD is postoperative day. POD is postoperative day. So postoperative day 1, POD 1, that is first postoperative day, the most common cause of fever is atelectasis or collapse of the alveoli. Atelectasis or collapse of the alveoli is the most common cause of fever. Which is why you will see on the first post-operative day, I still remember the first 6 months our role was to make sure when we take our morning rounds was to make the patient sit up and pat on the patient's back and make the patient do chest physiotherapy, right? And that is what the interns used to do. So to prevent atelectasis, we need to make sure that the patient does chest physiotherapy. Chest physiotherapy is done. And chest physiotherapy is usually carried out using an incentive spirometer. I'll just show you the image of an incentive spirometer. In fact, there was one question asked in the INI CET exam 2 or 3 years back from a spirometer as well. So chest physiotherapy needs to be done. Steam inhalation needs to be given. We need to treat CHF and COPD before admission, before surgery. If these patients have these things, they need to be treated before surgery. And we need to make sure that when the patient is getting admitted, he should stop smoking. He should stop smoking for at least 1 week before. He should stop smoking. Ideal is 4 to 6 weeks. Before, but at least 1 week before he should stop smoking. So these are the ways how we can prevent atelectasis and further development of pneumonia. This is an incentive spirometer. It is this device which has 3 balls in it, and you ask them to do this exercise so that it causes a lung expansion. Atelectasis, is collapse of the basal alveoli. And Dr. Krishna Kumar has already taught you that when you take a deep breath, first the apical alveoli fill up, then the mid-zone alveoli, and last the basal alveoli open up. So if the patient is not taking a deep breath because of pain, then there can be atelectasis. So that is why one more aspect to prevent atelectasis is adequate pain control. And this is a very important aspect which you should remember. So adequate pain control. So these things are the ones which will prevent atelectasis in the patient. Now, one of the questions which was asked in the INI CET exam regarding spirometry was whether you ask the patient to take a deep breath inside or you ask them to blow outside. So let me just demonstrate a short clip of spirometry to you so that you know about it. And when you go to the ward, you can also help patients do this exercise. So this you can see is a spirometer. The spirometer has a mouthpiece and the actual device has 3 balls in it, right? So the prime exercise which you have to teach to the patient is that first you tell the patient to take 2 or 3 deep breaths. Then you ask the patient to put this mouthpiece in the mouth and clench it with their teeth, right? And then you will ask the patient to take a deep breath inside. So you have to ask the patient to take a deep breath and hold the balls on the top for some time like this. Right? So when they do that, the lungs will get expanded and the basal alveoli will also open up. Now there is a method to place it upside down, and with this method you can ask the patient to blow into it. The patient can blow into it. But the prime exercise is when it is held upright and you ask the patient to take a deep breath inside. This incentive spirometer has become very popular, a household thing because of COVID. And I can tell you this was my best companion when I was admitted for 6 days in the hospital in isolation. This spirometer was my best companion. Now on post-operative day 2 or 3, day 2 or 3, if atelectasis is not corrected, then the patient can develop pneumonia. Right, so this is one of the causes of fever on day 2 and day 3. Pneumonia can develop. The other causes of fever, I've already told you about superficial thrombophlebitis. In the first module, I've already told you about superficial thrombophlebitis and how that can give rise to fever. And I'm sure as interns, all of you would have experienced that the nurses call you at odd hours in the night at 1 o'clock, 2 o'clock to change the cannula of a patient where there is swelling, right, because of superficial thrombophlebitis. And the third cause here is UTI, urinary tract infection. You should know as the most common cause of hospital-acquired infection or nosocomial infection. HAI is hospital-acquired infection. So this statement is very important. UTIs are the most common cause of hospital-acquired infection or nosocomial infection. And all this can manifest between day 2 and day 3. Day 4, day 5 is when the patient, so between post-operative day 3 to post-operative day 5, the patient can develop wound infection or surgical site infection. So wound infection or surgical site infection is defined as infection which occurs within 30 days of surgery, or if an implant has been placed within 1 year of the surgery. So this definition is extremely important. It is wound infection which develops within 30 days of surgery, or if an implant has been placed within 1 year of surgery. And this was a patient who had come to me. This patient had had a surgery elsewhere, and she had had a LD reconstruction, a latissimus dorsi reconstruction for the breast, and post that she developed severe wound infection, and you could see how much area has become necrotic and infected. So wound infection can occur between day 3 and day 5, and this can either be superficial SSI, that is above the fascia. It can be deep SSI below the fascia, or it can be organ space SSI around the organs. Another cause of fever on between day 3 and day 5, another cause of fever between day 3 and day 5 is DVT, that is deep venous thrombosis. It is deep venous thrombosis, and I've discussed this in detail in the venous surgery module, where I've told you that the patient will come with limb swelling and pain, and this is diagnosed using a Doppler. Now, ideally DVT should be prevented. And to prevent DVT, this also I've covered in detail in that module. You have pharmacological methods and you have mechanical methods. So you have pharmacological methods and there are mechanical methods. I've told you categorically that pharmacological methods are more superior than mechanical methods. And the pharmacological method which is used is low molecular weight heparin. The mechanical methods are early ambulation. And the use of pneumatic compression stockings. These pneumatic compression stockings you must have seen in the wards. So you must have seen these pneumatic compression stockings. They are tied on the limbs and they are connected to a pump. And when they inflate intermittently, they prevent stasis. And when stasis is prevented, DVT will not develop. So these are pneumatic compression stockings, and you should differentiate these pneumatic compression stockings from an anti-shock garment. This I've covered in the shock module. This is an anti-shock garment, and how you can differentiate the two is that an anti-shock garment will have numbering of 1, 2, 3 over it. And basically this anti-shock garment, what it does in hypovolemic shock, it pushes out all the blood from the peripheries to the heart. So that the cardiac output and the systolic BP can be maintained. So I've discussed about the causes of fever in day 1, day 2, day 3, and between day 3 and day 5. Another cause of fever which is specific to abdominal surgery is burst abdomen. And burst abdomen occurs around postoperative day 6. It occurs around postoperative day 6, and burst abdomen is also known as abdominal wound dehiscence. Is also known as abdominal wound dehiscence. That means basically the rectus sheath opens up. The rectus sheath opens up. That is abdominal wound dehiscence, when the rectus sheath opens up. And what are the signs which we will get? How do we know that the rectus sheath has opened up? So we get the salmon fluid sign. We get the salmon fluid sign, or the serous fluid sign, or the serous fluid sign. So the salmon fluid or the serous fluid sign, that means large quantities of serous fluid. That means large quantities of serous fluid will come out of the wound. Large quantities of serous fluid comes out of the wound, and that is what signifies that the rectus sheath has opened up. And you can see in this image, that the rectus sheath is completely opened up, and you can directly see the bowel beneath. You can see the bowel beneath it, right? Now, how do we manage these patients? First, I'll tell you the management, and then I'll tell you what are the predisposing factors which lead to burst abdomen and how can we control them. Right, so the management of burst abdomen, you have emergency management, and you have definitive management, right? The emergency management for burst abdomen is known as Urobag or Bogota bag laparostomy, right? So this is a Urobag laparostomy, and it is very simple. You know the Urobag, which is that plastic bag in the ward. So you just cut out that plastic bag and you cover the bowel with that plastic bag, right? So you can see that plastic bag, we've covered the bowel, and we suture it. We suture it with the rectus sheath or the skin. We suture it with the rectus sheath or the skin so that the bowel does not eviscerate, does not come out, right? And this is just a temporary measure. And because we have to suture it with the skin or the rectus sheath, we will usually use a cutting or a reverse cutting needle. And this was actually asked in the AIIMS exam 3 years back. So to carry out a Urobag laparostomy, we will use a cutting or a reverse cutting needle. So the emergency management I've told you is a Urobag or a Bogota bag laparostomy. Is a Urobag or a Bogota bag laparostomy. Whereas the definitive management is resuturing of the rectus sheath. The definitive management is resuturing of the rectus sheath. That is the definitive management in patients with a burst abdomen. And to resuture the rectus sheath, we know we will use Prolene sutures. Prolene is a non-absorbable suture. That is what will be used to suture the rectus sheath, as I've covered in the module previously. Now, what are the predisposing factors for burst abdomen? So this has been asked in the UPSC exam, and a lot of questions which are asked in the UPSC exam ultimately find their way in the NEET exam or the INI CET exam. So you should go over the UPSC exam papers and you should prepare those questions for your future exams as well. Now, the predisposing factors can either be patient-related factors or it can be surgeon or surgery-related factors. Or it can be surgeon or surgery-related factors. So the patient-related factors are chronic cough, constipation, infection, obesity, and immunocompromised patient. An immunocompromised, malnourished patient. So these are the patients where burst abdomen is common. The surgeon and the surgery related factors, what you should know, the risk is highest in a midline incision versus a transverse incision. So risk is highest in a midline incision versus a transverse incision. The second thing which you should know, that the risk is higher if emergency surgery is being done. emergency surgery versus elective surgery. Right? Because emergency surgery, usually either it'll be infected or the junior most person will be doing it at night and might not be thorough. So these are the causes. These are again, emergency surgeries have a higher rate of burst abdomen. Then continuous sutures, more common than interrupted sutures. Now, in the previous module, I told you that continuous sutures are usually used to close the rectus sheath. The problem is that if one of the continuous sutures opens up, the entire sheath will open up. Whereas interrupted sutures might be more time consuming, but the chances of burst abdomen are less. Having said that, majority of the times we take continuous sutures only to close the rectus sheath. And large bites more than small bites or short bites. So this is a trial which was concluded 3 or 4 years back, where they saw that if you took more than 1 centimeter rectus sheath bites as compared to 0.5 centimeter rectus sheath bites, where you were taking larger bites, the chances of burst abdomen was higher. That is why small or short bites are preferred when we are closing the rectus sheath. So final thing which you should remember, a short thread more than long thread. That is why if you remember the previous module, I told you that minimum 4 times the length of the wound. The length of the thread should be minimum 4 times the length of the rectus sheath wound. That is the ideal length of Prolene suture which we should use, minimum 4 times the length of the rectus sheath wound. If you use a shorter wound, it can cut through the rectus sheath and that can increase the chances of burst abdomen. So burst abdomen is a very, very important topic, and these points you should remember for the exam. Now, the final cause of postoperative fever which I want to talk about are intra-abdominal abscesses. Now, intra-abdominal abscesses can manifest anywhere between postoperative day 3 to postoperative day 7 and beyond. Right? So, these intra-abdominal abscesses means collection inside the abdomen. The most common site overall for intra-abdominal abscesses is the pelvis or the pouch of Douglas. That is the most common site for intra-abdominal collections, and this you should remember for the exam. The most common site in a supine patient, when the patient is lying supine, if we go back to anatomy, where Dr. Ravi Raj has taught you that in a supine patient, the most dependent position is the Morrison's pouch. Or the hepatorenal pouch. So if the patient is non-ambulatory, if the patient is supine, then the Morrison's pouch will be the most common site for intra-abdominal collections. And in an ambulatory patient, because of gravity, all the pus is going to trickle down and it is going to go into the pelvis or the pouch of Douglas. So overall, an ambulatory patient, it is pelvis or pouch of Douglas, whereas in a supine patient, it is the hepatorenal pouch. The clinical features of intra-abdominal abscesses, patients are going to come with spikes of fever. There will be spikes of fever with chills and rigors. Right? Now, if it is a collection in the pelvis, one peculiar presentation is pelvic diarrhea. And we used to see this quite frequently in the surgery ward when I was training at Safdarjung. So pelvic diarrhea is that when this pus collection in the pelvis, it will irritate the rectum. So the patient is going to have increased frequency of stools. But the patient will complain that whenever he passes stools, it is mainly mucus. With some fecal matter. So the patient would say that 8 or 10 times I'm going to pass stools, but mainly mucus is coming out and I have to go again and again. So that is the typical description of pelvic diarrhea, which signifies that there is a collection in the pelvis. If there is a subdiaphragmatic collection, then the patient can have cough, and can have breathing problems, can have cough and breathing problems. So these are some site-specific symptoms which can be there, but in general, the patient would be running fever with chills and rigors. And how do we diagnose intra-abdominal collections? The investigation of choice is a CECT. So whenever in doubt, we order a CECT to look for any collection. And if a collection is present, then we have to. So you can see here, this is a collection on CT. This is a collection on CECT, where you can see a pelvic abscess. And when we find this abscess, we will use a pigtail catheter to drain the collection. Pigtail catheter to drain the collection. This same pigtail catheter I've also shown in liver abscesses, where this can also be used in liver abscesses to drain them out. Okay, so this is a pigtail catheter. This has been asked in the exam, so you should know about this. So now moving on to the second aspect of this module, we will talk about surgical site infections and wound infections in detail. It is a very, very important topic from the point of view of the exam, because lots and lots of questions have been asked. So surgical site infection, I've already told you the definition of a surgical site infection. It is defined as wound infection which occurs within 30 days of surgery, or if an implant has been placed within 1 year of surgery. And it can be divided into superficial SSI, which is above the fascia, deep SSI, which is below the fascia, and organ space SSI. Now, surgical site infection, there are two scoring systems which are there, and you should know about these scoring systems because both of them have been mentioned in Bailey and Sebastian and have been asked multiple times in the exam. The first one is the asepsis wound score. The asepsis wound score, what I want you to remember is that the mnemonic for asepsis wound score is asepsis itself. A is additional treatment with antibiotics, drainage of pus or wound debridement. S stands for serous discharge, E is for erythema, P is for purulent exudate, S is for separation of deep tissue, I is for isolation of bacteria from the wound, and S is prolonged stay in the hospital. Okay, so this is a prognostic score which tells us about wound infection, and I want you to remember all these criteria. I just want you to remember the criteria. You can remember with the mnemonic asepsis. I don't want you to remember the scoring. The scoring is not important. So remember the term asepsis and these criteria. The Southampton wound score has also been asked extensively, especially in the AIIMS exam. And I want you to remember the Southampton wound score. 0 is normal healing. 1 is normal healing with bruising or erythema. 2 is erythema plus other signs of inflammation. 3 is clear or serous discharge. 4 is pus or purulent discharge. And 5 is separation of deep tissues. Right? I don't want you to remember the ABCD. That is not important for the exam. But these 1 to 5 you should remember for the exam. Now, what are the predisposing factors for wound infections? That is another thing which you should know for the exam. So this is a table directly out of Sebastian, the latest Sebastian. So you should know which all factors increase the risk of wound infections in patients. So extremes of age, recent surgery, coexistent infection. So supposing this is very common, what happens is that some patients might have an asymptomatic UTI, urinary tract infection. And if you carry out surgery on them, then they can develop a surgical site infection secondary to that urinary infection. So which is why at least I have made it a rule that all patients who are going to undergo any major breast cancer surgery under me, I get a urine routine microscopy done beforehand. Because if they have this asymptomatic urinary infection, I treat it with prophylactic antibiotics so as to reduce the risk of wound infections. Then diabetes mellitus is a very important risk factor, which is why we need to identify this and control the sugar adequately before taking up the patient for surgery. Corticosteroid therapy, hypocholesterolemia, obesity is a risk factor, malnutrition, chronic inflammation, irradiation prior at that site, hypothermia and hypoxia. So these are the predisposing factors for wound infections which you should know about. Now, the next thing which we need to talk about are the types of surgeries or the types of wounds. this table is a constant question, and there has been an update in the latest Bailey based on this table, which I want to highlight, and all of you should make a note of it. So you can have clean, contaminated, and dirty wounds. So the first type of wounds are clean wounds. The first type of wounds are clean wounds or clean surgeries. So clean wounds or clean surgeries, I want you to remember the examples of each one of them, because the examples are the ones which are being asked in the exam. So clean wounds are clean incised wounds like thyroid surgery, breast surgery, coronary artery bypass grafting, knee replacement, and uncomplicated hernia surgery. This has also been asked. Now these clean cases, if we use antibiotic prophylaxis or if we don't use antibiotic prophylaxis, the risk of surgical site infection is the same. It is 1 to 2%. So is there any advantage of using prophylactic antibiotics? Well, it does not seem so by looking at the percentages. So prophylactic antibiotics in clean wounds will only and only be used if you are placing an implant or a mesh. Right, so this is an important statement. There's no role of prophylactic antibiotics in clean wounds except when we are placing an implant or a mesh. Other than that, we will not use prophylactic antibiotics. And you need to remember these percentages. These are the ones which have been updated in the latest Bailey. The next type of wound is a clean contaminated wound. So clean contaminated wounds or clean contaminated surgeries are those where we enter the GI, that is gastrointestinal, or the genitourinary system when there is no inflammation there, right? When there's no inflammation. So examples are elective or interval cholecystectomy, elective appendicectomy. So if you remember the module on gallbladder and appendix, I will tell you there that if we don't operate in the immediate phase, then we'll call the patient after 6 weeks. We call them after 6 weeks because by that time the inflammation would have subsided. And when the inflammation subsides, that surgery is known as elective or interval surgery. So elective or interval cholecystectomy and appendicectomy are clean contaminated procedures. This you should know for the exam. Similarly, urinary stone removal when there is no UTI, and two very important surgeries which have been asked multiple times in the exam. LSCS, that is cesarean section, and laparoscopic abdominal hysterectomy also classify as clean contaminated procedures. And finally, you should also know bowel surgery if the bowel is prepared. What do you mean by prepared bowel? Well, as interns, you would have been asked to prepare the bowel by giving enema to the patient, right? By making the patient nil per oral before surgery. And for colonic surgeries, we give Pegleg. Pegleg is bowel preparation, which cleanses the bowel. So if you're doing bowel preparation and then operating the bowel, then it is a clean contaminated procedure. And in clean contaminated surgeries, the risk of wound infection with prophylactic antibiotic is just 3%, whereas without it is 6 to 9%. So there is a definitive role of using prophylactic antibiotics in clean contaminated wounds or clean contaminated surgeries. The next one is contaminated wounds. Contaminated wounds are when we enter the GI or the GU system when non-purulent inflammation is present. When non-purulent inflammation is present, that means emergency cholecystectomy, emergency appendicectomy, right? And bowel surgery in an obstructed bowel. So bowel obstruction surgery. Because in bowel obstruction surgery, we don't get time to prepare the bowel. So all bowel obstruction surgeries are contaminated surgeries. Please remember that. That is very important for the exam. And if we use antibiotic prophylaxis, the risk is 6%. If we don't use antibiotic prophylaxis, the risk is as high as 20%. So in these patients, prophylactic antibiotics should be used. Prophylactic antibiotics used plus antibiotics should be continued in the post-operative period as well, so as to reduce the risk of wound infection. Finally, you have dirty wounds. Dirty wounds are if there's pus present. So all abscesses will classify as dirty wounds. All patients with peritonitis, fecal and peritonitis contamination, fecal contamination will also classify as dirty wounds. Please remember, any neglected traumatic wound more than 6 hours, any neglected traumatic wound more than 6 hours classifies as a dirty wound as well. And dirty wounds, the wound infection rate with antibiotic prophylaxis is 7 to 8%. Without it is very high, that is 20 to 40%. So in these patients also we should use prophylactic antibiotics, and these antibiotics should be continued in the post-operative period as well. Now, like I told you, any neglected traumatic wound more than 6 hours classifies as a dirty wound. That is why 6 hours is the golden period for a traumatic wound. 6 hours is the golden period for a traumatic wound. Please don't confuse it with the golden hour in trauma. The golden hour in trauma was the first hour following trauma. Here, if you don't treat a traumatic wound, after 6 hours it becomes dirty. Now, there's another term which is mentioned in Bailey, and I don't want you to get confused with that. That term is the decisive period for a wound. The decisive period for a wound is 4 hours, and this is the time required. This is the time required for bacterial colonization. This is the time required for bacterial colonization after skin breach. After skin breach, this is the time required for bacterial colonization. That is why when we give the prophylactic antibiotics, we give the prophylactic antibiotics before the start of surgery, so that the antibiotic concentration is at its peak and it remains at its peak for at least 4 hours, so that wound infections can be prevented. So don't get confused between the golden period for trauma and the golden hour in trauma. Right? So golden period for a traumatic wound is 6 hours. Golden hour in trauma is the first hour following trauma. And decisive period is the 4 hours period in which bacterial colonization can occur after skin breach. So these are the 4 types of surgeries which you should know, and you should know the examples of each one of them. Now, there is one exception which I want you to know here: the early phase of duodenal perforation. The early phase of duodenal perforation peritonitis. Right? So the early phase, that means the first 6 hours, is the phase of chemical peritonitis. And this is the phase of chemical peritonitis, and at this time it is sterile. It is sterile. So although all peritonitis are dirty wounds, but the early phase will classify as a clean contaminated procedure. Will classify as a clean contaminated procedure. But if it is neglected, it will ultimately become dirty. So you should know this exception for your exam as well. Now, why is it important to know about these categories of wounds? One is that it tells you which wounds are more likely to become infected. And second, it helps in planning the OT list. So it helps in planning the OT list. So when we are planning the elective OT list, clean cases are always operated first. Clean cases are always operated first. Right? Why? Because clean cases have less risk of infection. So that is why we operate them first in the OT list, right? We will never do a contaminated or a dirty procedure first, because if you do a clean surgery after that, that can increase the risk of wound infections. So if you are the intern and if you've been asked to prepare the OT list, supposing a postgraduate has gone on a date or gone on dinner and next day the list has to be submitted, please always remember that clean cases will come first. We'll of course practice some questions towards the end of this module to reinforce this point. Now we've discussed about types of wounds and the risk of wound infection. The next obvious topic which we need to talk about is how to prevent wound infections. So how to prevent wound infections, the most important factor in preventing wound infections, the most important factor is proper hand hygiene. Or hand washing. This is the most important factor which is responsible to prevent wound infections. And you have the WHO guidelines for hand washing, which are depicted in this image. And I'll show you a short clip as well, in which I will demonstrate about the proper hand washing technique, because there are 3 questions which have been asked in the exam, once in NEET and twice in the INI CET exam. So in this video, I'll tell you what are the correct steps and that we should at least wash our hands for 2 minutes before any operative procedure. So these are the steps of hand washing. You can see that the hands are always kept hands up, elbows down. And first I just rinse my hands with water. Then I take liberal quantity of soap and I'm going to rub it adequately. I'm going to rub it on my palms and right down till my elbows. You can see that always my hands are up, elbows are down, so that all the dirty water can come down from the elbows. It's never the other way around. Now you can see the steps which I've highlighted. Rub the palms, then interlock on the other side. Then I'm going to interlock both my fingers. And then I'm going to start cleaning the thumbs on each side. And this is all similar to the image which I've shown you in the module. Once I've cleaned my thumb on both the sides, then I clean the tips of my fingers. In certain institutes, there is also a nail cleaner which is there, with which you can clean the nail beds as well. And once I've done that, I'm going to wash my hands adequately. Again, hands up, elbows down. This is just once that I've done it. I'm going to repeat the process again, and minimum hand wash should be at least 2 minutes. So like I showed you in the video, the correct steps of hand washing. Hand washing can either be done using soap and water, or it can be done using an alcohol hand rub, Now, soap and water versus alcohol hand rub have the same efficacy, except in 2 situations. Except if you visit the toilet, or if your hands are visibly soiled, in these 2 situations, soap and water is better. In these 2 situations. So look, the entire world has been hooked onto alcohol hand rub because of COVID. But these 2 situations, if you go to the toilet or if your hands are visibly soiled, if they have dirt on it, then soap and water is always better. Another question which was asked in the exam were the 5 moments of hand hygiene which have been described by WHO. 5 moments of hand hygiene when you should maintain your hand hygiene. So number 1 is before touching the patient. Number 2 is after touching the patient. Number 3 is if exposed to bodily fluids. If you touch patient's surroundings. And before any procedure, before and after any procedure. These are the 5 moments of hand hygiene where either you should wash your hands with soap and water or use an alcohol rub. The 2 exceptions I've told you where soap and water has to be done is when your hands are soiled or you go to the toilet, and this has been asked in the INI CET exam as well. Now, even if you wash your hands properly, there are 3 sides where contamination can still be left even after proper hand washing. And these 3 sides are the tips of the fingers, the interdigital areas, and the thumb. So these are the 3 sites where contamination can still be missed after a proper hand wash. So these were the points regarding hand washing which you should know, and that is the first step to prevent wound infection. The second step is part preparation. Now, part preparation has many aspects to it. Part preparation, the first aspect is hair removal. And I want you to remember, and this might come as a shocker to a lot of you, because a lot of you are products of government hospitals where shaving of the part is done, shaving of hair is done. And we also come from that era where, in the evening before surgery, there used to be an orderly who used to shave the parts of each of the patients who had to undergo surgery the next day. And invariably, we used to note that there were cuts after he had shaved. And it has been found out that shaving increases the wound infection rate. So I want you to remember this, that shaving of hair increases SSI rate, which is why shaving is not done these days. What we carry out is clipping of the hair. So what is best is clipping of the hair using a hair clipper. So clipping should be carried out. Clipping using hair clipper should be done. So the hair should just be trimmed rather than shaved, because that can increase the SSI rate. So once this has been done, once your part preparation has been done, you also have to clean the part before surgery. Right? So cleaning of the part before surgery is either done using betadine versus chlorhexidine and it has been found out that chlorhexidine plus alcohol preparation is better than povidone iodine or betadine preparation, Right. Now, how exactly do we clean the part? This is another thing which you should know for the exam. And cleaning of the part, if you're going to carry out any abdominal surgery, then for a male patient, the part is cleaned from the nipples to mid-thigh. And this question has been asked in the exam. For females, it is cleaned from the inframammary crease to the mid-thigh. So for females, it's from inframammary crease to the mid-thigh. And we are still talking about abdominal surgery. So I want you to know here, how exactly do we clean the part? So this is the abdomen. And this is the region of the thigh. So supposing you are assisting your postgraduate in an appendectomy or abdominal surgery, and this is this guy's first solo appendectomy. He's super excited, and he's so excited that he's busy washing his hands since the last 5 minutes. So he shouts out to you, he says that, please, why don't you clean the part? So when you have to clean the part, please remember that when we have to clean the abdomen, this is midline, this is lateral. So we will always go from midline to lateral. Okay. So 1, 2, 3, 4, 5, 6. We go from midline to lateral. Then we discard this swab. Right? Then we'll take another fresh swab. Again, midline to lateral on the other side. Right? So always it is from midline to lateral when we are cleaning the abdomen. But in the thigh and the perineum, this area is the dirty area. So because this area is the dirty area, I want to come last here. So when we are cleaning the thigh, it is always going to be lateral to medial. Similarly, on the other side, it is going to be lateral to medial. When we are cleaning the thigh. Abdomen is midline to lateral, thigh is lateral to medial. Please remember this. If you're doing limb surgery, if you are going to operate on a limb, supposing you have to operate around the elbow, you will clean till one joint up. You will clean and drape till the shoulder. Similarly, if you have to operate on the wrist, you clean up till the elbow. So always one joint up is what you have to clean. Also, one thing which you should remember, that after cleaning, please wait for it to dry out, right? Don't be in a hurry to operate when it's wet. So why do we wait for it to dry out? For 2 reasons. 1, it only becomes effective when it is dry. And number 2, if you have wet alcohol and you start using the cautery, you can get burns, right? So don't make that mistake. let it dry out. Now, another thing which you need to remember is, supposing there is a patient who has a sebaceous cyst over the forearm, and you as an intern have been asked to remove that sebaceous cyst, right? So when you have to clean that part, you will always clean the incision site. So this is my incision site, and then I will go circumferentially outwards. Then we go circumferentially outwards, right? So that is the correct method. Clean the incision site and go circumferentially outwards. Whereas this is wrong. We don't come circumferentially inwards and clean the incision site last. We go circumferentially outwards after cleaning the incision site. Okay? So these are the points which you need to remember in preparation of the part. Look, I'm being so practical because when the next exam comes in, these are the questions which you're going to get. It's going to be all practical. So I'm trying to transport you to the ward so that you can understand all these aspects. So we've discussed about part preparation, right? The third aspect is prophylactic antibiotic. So what is the best time to give prophylactic antibiotic? This question has also been asked many times in the exam. So the best time to give prophylactic antibiotic is 30 minutes to 1 hour before surgery. That is the best time to give prophylactic antibiotics. This question has been asked multiple times in the exam. Also, if prolonged surgery is there, then the prophylactic antibiotic is repeated. After 4 hours. The prophylactic antibiotic is repeated after 4 hours in prolonged surgery. Right? The other aspects to prevent wound infection are that OT parameters have to be taken into account. There should be ultra clean laminar airflow, which can filter 90% of the air by removing particles more than 0.5 millimeters. The general lighting to minimize eye fatigue, the ratio of intensity of general room lighting to surgical site should not exceed more than 1:5. Preferably it should be 1:3, and adequate illumination should be there. Also, you need to remember, to prevent wound infection, that we should prevent hypothermia. And to prevent hypothermia, the OT temperature should be between 18 to 22 degrees centigrade, right? Now, this is surgeon preference. I like to keep the OT around 18 degrees, but there are other surgeons who prefer it around 21, 22 degrees. So there's a range, 18 to 22 degrees can be the OT temperature. The relative humidity is between 50 to 60%. It should not be very high, because if it's very high, you will sweat a lot and that can increase the wound infection rate. And minimum 4 fresh air changes. In 1 hour should occur in the theater. Right? So minimum 4 fresh air changes should occur inside the theater within 1 hour. Right? And another way to prevent hypothermia is to use a bear hugger. Now, bear hugger is a device which blows hot air over the patient. So you can see here that this is the bear hugger. Which blows hot air over the patient, and it prevents hypothermia in the patient. The other aspects to prevent wound infection is to prevent hyperglycemia. So good diabetes control should be there. Proper hemostasis should be there. Proper hemostasis and dissection should be done. Please remember that washing the cavity with antibiotic solution is not helpful. is not helpful. So you must have sometimes seen that you would have postgraduates who after the surgery just douse the entire area with betadine, and they think by doing that, by washing the area with betadine, they're reducing the wound infection rate. Well, that does not happen. Okay, so just washing with saline is adequate. Just washing with saline is adequate. And in fact, by using all these antibiotic solutions, you just increase the risk of antibiotic resistance. Okay, so you don't need to do that in patients. Two more aspects which you should know about. Number one, there should be positive pressure inside the theater. There should be positive pressure inside the theater. There should be positive pressure inside the OT. And why do I want that? Do you remember the first module in surgery? I told you about the zones of the theater. I told you the sterile zone is the OT, right? So I want the cleanest air inside the theater. Now, if there is negative pressure, it will suck in air from the other zones of the theater. I don't want that. I want that when the theater door opens up, air should go out from the theater, not come in. Right? So air should go out from the theater. That is why I want a positive pressure of at least 2 millimeters mercury above the atmospheric pressure inside the theater. Also, giving oxygen in immediate postoperative period. Giving oxygen in immediate postoperative period reduces SSI rate. This reduces the surgical site infection rate. And finally, you should know this is the recent update which has been mentioned in the recent updates manual and in the latest Sebastian. This is a dual ring abdominal wound protector. Also reduces SSI in abdominal surgeries. Also reduces SSI in abdominal surgeries. So what is this dual ring wound protector? So this dual ring wound protector is before we open up the abdomen, we are going to introduce this dual ring protector, and this has an outer ring. This is an outer ring which comes outside. It has impervious plastic. It has impervious plastic and it has an inner ring. Right? So this dual ring wound protector would basically prevent the peritonitis contents or pus inside the abdomen to come in contact with the skin, and it will prevent wound infections. So these are the various ways how wound infection can be prevented. This is again a super important topic, especially the hand hygiene part, the part preparation part, and the prophylactic antibiotic part are a sure shot thing from which questions can be asked in the exam. Now, before we end this module, because of COVID, we all have become akin to wearing these protective devices, the personal protective devices. And there have been 2 or 3 questions regarding personal protective devices, regarding the donning and doffing, wearing and removal of these personal protective devices. Now, I'm going to share the points which are mentioned in a YouTube video in the official AIIMS channel, because every association has different guidelines regarding wearing and removal of these personal protective equipment. So we are going to follow what is done in AIIMS because most of the questions have been asked in the INI-CET exam. So donning and doffing. Donning means wearing. Donning means wearing of these personal protective equipment, PPEs, personal protective equipment. First, you have to wash your hands. Then you wear the first pair of gloves, which is optional. Some people just wear 1 pair of gloves. Then you wear the gown, then the shoe cover. Then you wear your mask. After the mask, you wear your goggles. Then the face shield, and finally the gloves. So this is the sequence in which we wear these personal protective devices. How do we remove them? Removal is equally important because if you're not careful while removing them, you can get infected, right? So removal of these personal protective devices, you disinfect your gloves first, then remove the shoe cover, remove outer pair of gloves if you're wearing them, face shield, gown has to be removed, then inner gloves, and finally the mask has to be removed. So this is how we wear and we remove personal protective equipment. So this brings us to this end of this very, very important module, and you can expect at least 1 to 2 questions from this module in all exams. Now for final year students, what is important is the classification of wounds, into clean, contaminated, and dirty. That is a short note for your college exam, which is frequently asked. You should also know about the causes of post-operative fever, and burst abdomen is also a short note which is asked in the college exams. So these are the points which you should remember. Before we end this module, let's quickly do some MCQs. The prevention of wound infections, which statements is not true? So true and false. On-table clipping of hair is the best way to remove hair from an operative site. This is true, I told you. Washing the wound cavity with antibiotic solution after surgery reduces the wound infection rate. This is false. A dual ring abdominal wound protector is superior than a single ring. This I told you is true. In prolonged surgery, prophylactic antibiotics should be repeated after 4 hours. This is true. And in a female patient undergoing abdominal surgery, parts should be cleaned from the inframammary fold to the mid-thigh. This is also true. Hypothermia reduces the risk of wound infection. No, this is false. All of the following factors increase the risk of wound infection except obesity, yes, jaundice, yes, cancer, yes, hypertension does not. So hypertension does not increase the risk of wound infection. This was asked in the INI-CET exam. So which of the following surgeries has not been matched correctly? LSCS is clean, contaminated is true. Ileal perforation, dirty is true. Right hemicolectomy in a patient with prepared bowel. Remember, prepared bowel, clean, contaminated is true. Lap chole in acute cholecystitis, clean, contaminated is false. This is contaminated because it is emergency lap chole. Ischiorectal abscess is dirty. Knee replacement is clean. Early phase of duodenal perforation is clean, contaminated. And intestinal obstruction surgery, I told you, is a contaminated surgery. You have 4 cases posted for surgery the next day. So this is the question which I was talking about. And you are the intern. You have to prepare the OT list for the next day. You have a 70-year-old lady with long-standing diabetes and hypertension for a breast lumpectomy. You know breast lumpectomy is a clean surgery. You have a 45-year-old fit male for lap chole. This is clean, contaminated surgery. Then you have 35-year-old female with lap abdominal hysterectomy. This is also clean, contaminated. And you have a 40-year-old female for mastectomy. This is also clean. Yes, so which one will you post first in the OT list? Remember, I told you that we always post clean cases first. So now you have 2 clean cases. So which one will you go for first? I bet most of you have answered D. Right? Most of you have answered D. Well, D is wrong. We'll first take this old lady for surgery. Please remember, whenever you have multiple clean cases, we will use some common sense, right? Some common sense has to be used. And common sense says that patients with comorbidities, elderly patients, you don't keep them fasting for long periods. So you will take them up for surgery first. A 34-year-old patient underwent laparotomy for ileal perforation and was recovering well, but on the 8th day, he started complaining of multiple episodes of loose motions, which comprised mainly of mucus. Spikes of fever were also present. Remember, this is a classical definition for pelvic diarrhea. And what does this signify? Correct. This signifies that there is a collection in the pelvis. There is a collection in the pelvis. The final question, this was asked in the UPSC exam, very important question. Review the following statements regarding burst abdomen. Usually presents as salmon fluid sign. This is true. Reddish fluid coming out. Incidence is more common with transverse as compared to a midline incision. This is false. It is midline more than transverse. Emergency management is Eurobac or Bogota bag. This is true. Incidence is increased if Prolene sutures less than 4 centimeters. Less than 4 times the length is used. This is also true. That's why we should use adequate length. Higher incidence if non-absorbable sutures are used. This is false. We prefer non-absorbable sutures, although PDS, polydioxazine, can also be used, but we usually prefer non-absorbable sutures. Higher incidence in patients with chronic cough and constipation. This is also true. So the statements which are false are B and E. And this is your multiple correct type question for the INI CET exam as well. So this brings us to the end of this very important module. This is a practically important module as well, because when you work as interns or postgraduates in the surgery ward, you should be aware of these points. Thank you.